Hi, everyone. Welcome to the Interstitial Lung Disease Info podcast. In this episode, I'd like to talk about pragmatic treatment decisions clinicians may sometimes make in treating patients with idiopathic pulmonary fibrosis. So, basically, at this moment in 2022, we don't really have very good treatments for IPF. This is very unfortunate, but we only have two antifibrotics which are approved, pirfenidone and nintedanib. And they only slow down the generally inevitable progression of IPF. So they don't fix the problem. Patients don't feel better when they go on these medications, but it does slow down the long-term progression of the disease, which some patients would want. Of course, we want to prevent for as long as possible the onset of respiratory failure. But to complicate matters further, in certain countries, so in the example of the country where I practice or where I live, the United Kingdom, there are certain rules that further limit prescribing of these medications. So you can only prescribe antifibrotic medications if your patient has a forced vital capacity of 50 to 80% of predicted. So this is the rule for reimbursement in the United Kingdom. And other countries may have various rules around this. Now, I do understand that there's a rationale for this, for economic reasons and for logistical reasons, and to make sure that actually patients who do have IPF actually receive the medications. But it does create some situations which I will outline in some examples. So basically, pragmatic decisions sometimes need to be made when starting antifibrotics for IPF in this context, because the system is designed in this way. So what may happen is that some clinicians may actually force a working diagnosis of IPF, as this gives the patient more treatment options. So many clinicians who are fairly convinced that an IPF diagnosis is the most likely will just simply go with this diagnosis without digging any further to allow their patients to access both antifibrotics, including nintedanib and pirfenidone. So this may be even in cases when a progressive fibrotic interstitial lung disease, or PF-ILD, is actually plausible, and the potential cause for the patient's fibrosis may actually be found if we look deep enough and we run enough tests. But we don't have an incentive for that, because unfortunately for progressive fibrotic ILD, only nintedanib is currently approved, and there may be contraindications sometimes. So therefore, by not making a diagnosis of IPF, even in questionable cases, many clinicians will feel that actually they are offering more options to patients. So avoiding a diagnosis of progressive fibrotic ILD and making a precise phenotypic diagnosis, we actually offer more treatment options. I do want to stress that the very word idiopathic refers to an undetermined cause, but we need to look quite extensively to find that it is indeed undetermined. So we're being put in a situation in which this idiopathic diagnosis is actually offering more options than a specific, precise diagnosis would. And I feel this takes a little bit away from the precision of medicine and the clinical science that we're trying to implement. And we're becoming a little bit algorithmic in our treatment and diagnostic approach. The other thing that may happen is that sometimes clinicians may calculate a percent predicted forced vital capacity based on GLI predictions. So the Global Lung Function Initiative predicted values usually yield slightly lower FVC values compared to other forms of GLI, to other forms of prediction, which are not GLI. Now, obviously, most lung function labs nowadays do report in GLI. However, many clinicians will sometimes check this very clearly to just make extra sure that patients who are slightly borderline, so for example, a patient who may come in with an FVC of 82% predicted, non-GLI, usually if a calculation is made according to GLI equations, it may yield an FVC value of 79% or 80%, which may sometimes be enough to ensure that antifibrotics can be prescribed, because there is no specification on which prediction system is actually used for the cutoff. So sometimes this is another pragmatic decision that clinicians might take. And the final thing would be that basically we end up making decisions and diagnostic decisions based on potential treatments available rather than making the best diagnosis and then providing the treatment, which builds a little bit on the first point that we discussed. So we are actually just trying to find the right diagnosis that can allow us to prescribe the treatment, because we do know that these antifibrotics do slow down progression in most fibrotic lung diseases. So we're basically just trying to lump everyone together in order to provide the treatment. Even though in most cases this may actually be right, as antifibrotics may slow down any kind of progressive fibrotic ILD, this does seem to me that we are actually stunting the field of ILD. We're stunting progress because of this approach, because clinicians are not being put in a position to actually look hard for a precise diagnosis, to establish phenotypic differences between patients who they are treating, even though they carry the same IPF label, because this is a diagnosis of exclusion. And under that umbrella of IPF, there may be many, many phenotypes. We know that there are patients who stay stable for years and years and years, but still have a diagnosis of IPF. And then we know that some patients with IPF have a lung function progression that's absolutely astounding. And within a year or two, they end up in respiratory failure. So actually making these differences is probably very important to actually provide some form of personalized medicine in the future. But unfortunately, by lumping everyone together under the label of IPF and just to get them on antifibrotics seems a little bit, at least to me, seems a little bit odd. And I do understand that these cutoff values need to be established in order to prevent inappropriate prescription of antifibrotics. This does make sense from an economical point of view and also potentially from a scientific point of view as well, because it's rare to find IPF cases with completely normal lung function. But it does force clinicians somehow to apply some rules that limit their creativity and their clinical judgment. And then patients ultimately receive an imprecise diagnosis sometimes, and a treatment that may be only good enough for them. It may not be the best. It may just be good enough for their case. And I do worry that many patients with particular phenotypes of idiopathic, as we call it, pulmonary fibrosis, may actually benefit from a more thorough investigation and personalized therapy, but they will unfortunately be lumped together with everyone else. And in this situation, I do wonder, is this really in the best interest of our patients? Are these limits somehow counterproductive? This still haunts me sometimes, this question. So I hope this was an interesting perspective for you, if you work in the field of ILD or if you're trying to learn about the field, if you're interested in the field. These are some of the decisions we are sometimes faced with as clinicians who treat patients with interstitial lung disease. Hope this was helpful, and if you enjoyed this, I'll try to make more content about ILD in the future. So do subscribe to the podcast, to the YouTube channel, and make sure you check out the website interstitiallungdisease.info. See you in future episodes. All the best.